All right.
Awesome.
Well, thanks for having me to, 2 months in a row to hit you over the head with EMS stuff. So that's fun. I promise I will only briefly talk about out of hospital cardiac arrest today, and at least it'll be traumatic cardiac arrest. So for those of you who are sick of hearing me yammer on about that stuff, we're going to talk about something a little different today. We've got a little quick EMS nibble here. We're going to do one LifePact case that came up in the last month. Really interesting case, well managed by the team, a lot of interventions, a lot of interesting discussion points, and I only got a half hour, so I'm going to jump right into it. This was a case of a patient who had fallen off a ladder pretty significantly, not a tiny ladder like this, can stock image, but like a 30-foot ladder. And EMS arrived on scene and basically couldn't manage the guy's airway because there was so much blood in it. So they diverted to their closest hospital, which was Landmark. And the patient was promptly intubated, and almost immediately it was recognized this patient was a multi-trauma and therefore needed to come to a trauma center. So transfer arrangements were made. LifePact was dispatched. Patient was hypotensive prior to LifePact getting on scene, and that's why we went. So at Landmark, patient's collar, GCS3, there's an endotracheal tube in place, mechanical ventilation as noted. And we immediately went into our ABC, just like you would in a normal trauma case, and found that the patient had diminished or absent breath sounds on the left side. No obvious flail chest. There was a lot of blood coming from the mouth and nose, requiring basically continuous suctioning. The patient did not look great. He was diaphoretic and pale. He had a blown pupil and had very significant facial trauma. Belly was soft and pelvis were stable, and we didn't see anything obvious in the extremities. Patient at Landmark had been intubated, had a whole bunch of IV access established, had an OG tube, urinary catheter, and already gotten 4 units of emergent blood just in the time of arrival to LifePact showing up. So this is a pretty highly unstable trauma patient, and they're doing the best they can. For those of you who've been to the Landmark Emergency Department, it is your typical community emergency department. And so this is the kind of case that breaks a department like that because they just aren't used to managing them. But they actually did a reasonable evaluation of this patient. So for all the ATLS folks in here, what have we identified as the patient's major problem just in our primary and brief secondary survey? Anybody want to chime in? This is interactive. Come on, they're hypotensive. What's wrong with them? I can't see the chat. Sorry. So if someone can look at the chat and let me know if people are typing in there.
Hey, Nick, you said absent breath sounds on one side, hypotensive, tachycardic, and blood in the ET tube, right?
Blood around the ET tube, but yes, so, otherwise,
presumably it's going to be a tension, either pneumo or hemothorax or some blunt cardiac or great vessel injury.
Perfect. All right. So it's kind of a broad differential, but just on our basic thing, we've got, we're not moving a lot of air on the left side. I would add one more thing into that, which we see sometimes at outside hospitals, which would be a right main stem intubation, which happens sometimes, particularly in the younger populations. We just tend to put the tube in too deep. But yeah, this is a trauma patient with absent breath sounds who's not doing so hot. So great. All right. So we're in the trauma room, and that's when we get started. All right. We're like, this patient's likely has a pneumothorax. Actually, there's a chest x-ray that showed that. I didn't tell you that. And we said, you know what, we're ventilating a patient with a known pneumothorax who's ventilating and oxygenating. Okay, let's back off on our tidal volume so that we're not massively inflating that pneumothorax. And then we're going to do a decompression. So they did a pleural decompression with the 3 1/4 inch catheters, which I'll show you what they look like. Minimal release of air, and then they attached a stopcock, which allows you to just continually vent it if you need to, which is sort of an added hack in the field. You got to secure that catheter so it doesn't kink. So a lot of times we see them come in taped, and when you tape them down, you actually kink the catheter and then it stops working, or you pull it out. So you put bulky dressings around it so that the catheter is still sticking perpendicular to the patient's skin, and that allows you to secure it in place, almost the way you would secure an impaled foreign body. We did lots of oropharyngeal suctioning. This is including a patient who has an OG tube. So this is upper airway or upper oropharynx bleeding. took the patient off their longboard because we didn't think they needed it, got them onto our stretcher, secured them, started getting ready to transport. Patient got worse, got a little push dose epinephrine. We started Levophed, and then we got blood pressures into the 80s and we started transport. We have good end tidal, noting that our tube is in the right spot. This is all from the paramedic note. This is the doc note. So we've got that, again, that fixed pupil. We've got the absent breath sound. She's documenting that the paramedic did the needle decompression and that we switched from volume control to pressure control to try and get down on those volumes. We performed it fast. We were questioning something in the left upper quadrant and then a question of a pericardial effusion. No obvious blood in the pelvis. And again, we decompressed him in the second intercostal, and we'll talk about that. Got a quick pelvic x-ray just to make sure that we didn't have an open book that we needed to put a binder on, which I think is a really smart move by the docs care and paramedics caring for this case. Like, you've got portable x-ray, get a look at the pelvis before you go for a half-hour ride, and know that you can put a teapot on the patient before they go and help to stabilize them. Also smart, ask for more blood. It's better to give blood than crystalloids. And given the amount of blood that was coming out of the patient's oropharynx, we felt pretty strongly that we needed to have some additional colloidal resuscitation for the patient. And then I think this is where we're going to talk about here. Given a relatively stable patient, sort of in quotes, concern for abdominal, possibly cardiac trauma, in addition to pneumothorax, moved the patient to deferred definitive chest tube to Rhode Island Hospital. And we can talk a little bit about this decision making. This wasn't done in a vacuum. This was done in consultation with me, actually, because I was the MDoc that day. But sort of deciding, we've done as much as we really can do here. We've got the patient pseudo-stable. This patient needs an operating room. Let's go. That's the landmark chest x-ray. You kind of lose the costal margin on the left, but what you see is a very large pneumothorax, which certainly was appropriately intervened on by the team. Endotracheal tube in place, and just looking at it right now, it looks like the OG tube might be pretty shallow, but we'll see. So patients now on our stretcher, we've gotten a little bit of push dose meds. We're getting additional blood. We're starting on Levophed, and we're out in the back of the truck with lots of pumps and stuff going. And the medic is documenting the patient's relative size and ideal body weight so we can calculate an appropriate milliliters per kilogram. And you see what the tidal volumes are in the pressure control mode. So we've ramped it down, but the patient's still satting well with decent end tidals, which is an appropriate way to manage this patient. Also decreases your intrathoracic pressure. Now they're on the road and the patient's blood pressure goes down to the 40s. We are out of blood, so we hang what we have, which is fluid. TXA was next on our list, so we give that. And then the crux of this is that we've got a decompensating patient with a known sort of unprotected pneumothorax who is getting worse despite appropriate efforts. And so basically on Route 146, we did a finger thoracostomy. We do have the ability to do tube thoracostomies on LifePact. We carry the equipment, but for those of you who have been in the back of an ambulance, that's probably not the best place to do a tube thoracostomy. Those kits are more on board if we're doing a longer transport and need to put a tube in, or if we get to an outside hospital so that we have a kit that we know and understand. So got a huge rush of air when we did that. Blood pressure responded appropriately. Tidal volumes actually went up as the lung re-expanded. And the last thing that sort of was on their list of things to do was to hang 23% because this patient did have a head injury as well. And that was sort of deferred to the ED because we just ran out of time. A lot of good thinking went into this discussion. And in fact, I was on the phone with the team the whole time and they delegated appropriately. The paramedic was very busy. The doc was obviously very busy. The one thing that they needed me to do as the MDoc, aside from giving them some advice, was to actually call in the entry note. So I called in the entry note to MedCom, and so that MedCom could activate the trauma team and get a room ready. And I would just add that it's COVID times. And so the crew did this with maximal precautions. So the level of sweat and grossness was probably pretty extreme, but the care for the patient was really excellent, which is why I wanted to highlight it. At Rhode Island Hospital, immediately into a trauma room, chest tube placed with some expansion of the lung on repeat chest x-ray. They started damage control resuscitation. The patient now has a positive FAST exam in the left upper quadrant and goes directly to the operating room. In the operating room, the patient does not have as much bleeding as you would expect intra-abdominally. There is some splenic hematoma and some scattered retroperitoneal hematoma noted. But there's this bulging diaphragm, so they actually placed a second chest tube in case that there was a reaccumulation if the first chest tube wasn't working. And then they brought in a second trauma surgeon because they're like, where the heck is this patient hypotensive from? And there was thought that there was pretty significant head trauma and upper airway trauma. And so they actually packed the patient's oropharynx in hopes of tamponading that. And then on the way to the TICU, they stopped by the CAT scanner and got a pan scan. And unfortunately, the pan scan showed pretty significant intracranial injuries. You can see numerous skull fractures just on this one little slice, and significant hematoma and swelling as noted by the crew that sort of obscured their view of the patient's left eye because it was just too darn swollen. In light of this horrible prognosis from this CAT scan and the patient's instability, they sort of had a conversation with the family, and it was elected to make the patient CMO, and he expired on the same day that he was transported. So a sad case with a difficult outcome in the end, but I think a worthy one to discuss as a group. Interestingly, the resident involved was wearing their heart rate monitor, and you can see what happened over the course of the call with the inverse correlation between the patient's blood pressure and your heart rate. Interestingly, the paramedic's heart rate was not quite as high as the doc's. Paramedic was a little, maybe they're on a beta blocker, I don't know, but I thought that was funny. And shared with permission, by the way. So I think this is a great case of like the dynamics of trauma in the field, and why as EMS docs we're always hammering home to our agencies in the field that if it's at all possible, they need to take trauma patients to the trauma center, because this patient had hours added on to their transfer. In this case, if you can't effectively manage the patient's airway, you have to bring them to a place that can effectively manage the patient's airway. But the problem is once that happens, then you're adding hours on and lag time. So there's an automatic delay in definitive care. So we sort of teach our crews like, yes, if you think you absolutely have to stop, you can stop. But really, let's try and take away the excuse of I'm uncomfortable, the patient's hypotensive. Like, you've got stuff for that. You have vasopressors, you have fluids, you have needle decompression. Like, get the patient to the definitive care first, or it's just going to cascade pretty significant delays in care down. I don't think any of that had anything to do with this patient's outcome. I think falling off of the ladder as high as the patient did was what led to these injuries. And then I think there's this great discussion of what the patient needs versus what the patient needs right now. And I think that different docs would approach this call differently in terms of put in the chest tube, don't put in the chest tube at the outside hospital. We all know the patient needs one. And the question is how much time is it going to take to put the chest tube at the outside hospital? How much is that going to gain us in transfer? And what is our backup? And so that was the discussion I had with the resident when we were talking about the case was, you know, it's not wrong to put in a chest tube, but it's also not wrong to go with a plan for a backup. And that's a little bit of what I wanted to address today with you all. So any questions about that case or comments before I move on to a little teaching? For those of you who put in a chest tube at an outside hospital, it can be a harrowing experience because you're using a kit you've never used and you don't know what's in it. And you know, I remember I asked for the chest tube kit when I was at Newport, even our own facility, and they brought me this kit that had like metal trocars and dilators in it from like the 1960s. So you could be very surprised by the equipment that you get, which is one reason we do carry some. It's not the exact kit that we carry in the trauma room, but it's pretty darn close. And it's obviously the same Pleurovac. So some of it's consistent, some of it's a little bit different. All right, so managing pneumothorax or hemothorax in the EMS environment is a very important skill. It's a skill that surprisingly few providers in Rhode Island are empowered to do because this is a paramedic skill. And so there just aren't a lot of paramedics in Rhode Island. So when you look at the things that are different in the scope of practice between a paramedic and an EMT cardiac, this is one that sort of reigns supreme. So we know that thoracostomy is putting a hole in the chest. You can do it as a needle thoracostomy, what we call commonly a needle decompression. You can do a tube thoracostomy, which is what we call a chest tube. And you can do a finger thoracostomy, which is where you poke your hole in, evacuate the air, and then pull your finger out. You do everything but put the tube in. Again, paramedic skill. Needle thoracostomy is a paramedic only skill. So, and there's actually some logistical barriers, even for the paramedics who work in a system that only have cardiacs. They don't have the same access to the needles that the paramedics that work on paramedic licensed trucks have. So that's really the kind of needle you want to be doing this, and I'll talk to you a little bit about why. From an anatomical standpoint, midclavicular line, second intercostal is traditionally taught. I think the origins of that are both in the general size of patients at the time those recommendations were made. We are a lot larger than we were then, but also in just ease of access. So accessing the anterior chest is pretty easy on most patients in an EMS environment, but once you get them on a backboard or in a Stokes basket, it can be a little challenging. Interestingly, in the tactical environment, we've been utilizing the fourth and fifth intercostal space for a long time. And the reason is you can do that while you're still prone next to the patient. And it's also much easier to access the patient's axilla while keeping their body armor on than trying to take off their body armor if you're under fire. So the military medics and tactical medics have been using this alternative approach for a long time. And I'm going to argue that we should really be using this alternative approach based on the evidence. So there's your traditional location, and that's your traditional tube thoracostomy anterior axillary line, fourth, fifth intercostal. So just to review quickly, remember the neurovascular bundle is on the lower portion of the rib. So you want to ride the top of the rib as you're going through. This person allowed themselves to be colored, so you know where everything is. So you sort of feel along the rib, ride it down until you get a rush of air. Many of us will put a syringe on that, so you actually get that feedback of knowing that you're in. Some people do it without, but I recommend my crews do it with a syringe. And note that it's best to be perpendicular as you ride the rib because you want to take the shortest path through the chest. If you go in at any sort of an angle, you're just increasing the distance of tissue you have to go through, which is decreasing your chance of being successful of getting all the way through. So wrong spot. It's actually harder than it looks, especially in the darkness and in EMS environment that we work in. Patients are obese and it's hard to find those and palpate those locations. Oftentimes we're not using a long enough needle. So we might be getting through and then the needle pops out or the catheter pops out and we're no longer decompressing the chest. Or the needle or the catheter doesn't stay in long enough. So that can be another challenge. And if you're doing compressions on a patient, those are going to pop out pretty quickly. So, you know, again, in a tactical environment, you get a chest seal on a patient, and then they're taught to needle the chest as soon as possible. And this is the world of EMS, right? It's dirty, it's dark, it's wet, you have poor visibility. And in some cases, you have people shooting at you, which makes life a little interesting. So they did this very interesting study where they just sort of asked providers where to put it. And it was actually ED physicians. It was sort of a convenient sample. It's obviously not the definitive literature, but it's an interesting study. And most of these had ATLS certification. And only 16 identified the correct location as either the second intercostal or the fourth or fifth anterior axillary line. And 2 people actually identified the site of pericardiocentesis, so totally misunderstood how you decompress the chest. And they actually did this cool thing where they showed you where people, each one of those dots is a person, and you see where people sort of selected. And what they found in general is that most people choose to go too medial, which I have done before in a code, and that produces a nice fountain of blood as you catheterize one of the great vessels. So I don't recommend doing it. So really, midclavicular line is farther over than you think it is. And so we often end up actually performing this more medial than we have to. This is a great example of sort of showing how you would do it. In this case, the patient's got an occlusive dressing for a sucking chest wound in place. We've had a lot of discussions about when to decompress, when not to. So if you have a traditional chest seal in place that has the ability to burp, you could technically burp the chest seal if you have, because that's your hole, that's your thoracostomy, is their sucking chest wound. So you put an occlusive dressing on it and you can burp it and burp the air out. But if you're not getting where you need to with that, you absolutely can proceed to needling the chest. And the military teaches their people to needle the chest, even if there is a chest seal in place. And the reasoning behind that is the environment they work in. I can't see the chat. I don't know if there's anything I should address in there. All right. Again, you want to go perpendicular. The more angle you take, the more tissue you got to travel through before you get in. So I think it's important to understand what our different catheters look like. So these are sort of your standard IV catheters, and they're usually 1.25 inches, which is 3 centimeters, and keep that number in mind. The average person who works on a cardiac level ambulance, no matter what the provider's licensure level, this is what they have access to, is a 3 centimeter catheter. For those of you like Crocodile Dundee, like you need a real knife, you need a real big needle, and that's where these folks come in. We carry them on the LifePact truck. They tend to walk because people collect them for their personal kits, but these needles work great. There is a little bit of a sharp risk with them because there is no retractable needle. It's just a big harpoon. And that's an 8 centimeter needle. So in most patients, you're gonna get where you need to get. And just a difference, just to appreciate the difference in the length of the catheters. So somebody actually looked at this. Many people did, and then somebody did a meta-analysis of it, and they looked at the different anatomical locations, both mid-axillary and anterior axillary line, as well as the traditional second intercostal midclavicular. And what you see is that you're at about 3.5 centimeters if you go down into the anterior axillary line, but everywhere else you're in the 4 to 4.5 centimeter range. So your traditional IV catheter is just not going to get through. We often substitute with a 2.5 inch needle, which is that big 14 gauge or 12 gauge angiocath, like the ones that we use for IV or ultrasound guided IVs. That's a decent, that'll get you 5 centimeters, which will probably get you through. But in reality, those big 8 centimeter ones are really the best. So basically what they said is, when they're coming out with these trauma guidelines, they're saying, using this large catheter is better in both locations, but obtaining access can be challenging in the lateral approach. So that's what they're balancing out with this. And ATLS is recommending something that might not be sufficient to get through, because I think they're saying up to a 5 centimeter catheter, which probably will get through on most people, but on some people it won't. So their meta-analysis sort of said ATLS should probably be recommending this longer needle. And consider an alternative catheter location to get you in. So basically, the 5 centimeter needle is going to fail half the time at the second intercostal space. And it's going to fail a lot less if you go anterior axillary. So their sort of argument is to go there, which is a practice that I've taken up. So if I have the big 8 centimeter one, I can go anterior. It's easier to get to. It's easier to secure. It stays out of the way of the site that someone's going to put a chest tube in the patient. But if you don't have that big catheter, you should be thinking about going into the anterior axillary line. All right, we got 5 minutes. Finger thoracostomies. If anyone has questions about how to do finger thoracostomies, you can talk to Dr. Miles, who is now our resident expert on them. And I would say Dr. Rybasak would be the faculty expert on performing them. They saved a guy's life who was crumping in critical care by doing bilateral finger thoracostomies on him. much to the chagrin of our trauma colleagues. I should point out, I didn't look to see, I don't think any trauma friends are on here, but someplace at Rhode Island Hospital, there's a trauma surgeon getting a trill on the back of their neck as we're talking about this. But I think we don't need to do these on every patient, but I think this is a skill that we should understand, and particularly in austere environments, understand the value of making this intervention. So sometimes a needle decompression doesn't work and you need a bigger hole. There's blood in there, et cetera. And the challenge from an EMS standpoint, and actually from our standpoint, is you're doing CPR on somebody maybe who's coding, and you've got sharps infection concerns, which is a valid concern for our trauma colleagues who are going to manage these patients down the line. We don't necessarily have ANSEF to give them as we're doing these decompressions. And then trauma surgery pushes back when we do it, as they did most recently when Dr. Miles did these. Although that patient both survived to discharge intact and did not get an empyema. So our N of 1 looks pretty good. The real thing where I think these are valuable is before they get to us in the emergency department. This is an interesting study. It's a single system study, which you always have to, like, that throws red flags out, like what's going on in the system. It's a pretty high-end system. It is a sort of rural suburban county with long transport times to the emergency department. And they did a 4-year retrospective review, and they found 57 patients who had traumatic cardiac arrest who were treated with a field thoracostomy, either finger thoracostomy or what they called an improvised tube thoracostomy, and about a 70-30 split on blunt and penetrating. And the reason I bring this up is I feel like there's this nihilism among our trauma colleagues when patients come in with blunt cardiac arrest, that they all have great vessel injuries and are going to be non-survivable, and if they have no signs of life, et cetera. And I would agree that the large trauma registry data supports that, but I'm going to show you some data here that should scare you and should make us want to be more aggressive about how we manage these patients on scene before they get to us. So 30% of the time when they did this, they just did this at a protocol. If you had a traumatic out-of-hospital cardiac arrest, you got finger thoracostomies. That's just what they did on everybody, unless there was a sign that you were like decapitated or not going to survive. 25% of those, so 1 in 4 patients who got bilateral thoracostomies had ROSC, and 7% survived intact. Those are really important numbers. 7% surviving intact is actually exactly the current survival rate in Rhode Island from out-of-hospital non-traumatic cardiac arrest, which is to say there's a huge population of patients who likely have tension pneumothorax, thinking somewhere in the 25 to 30% in this cohort, that benefit from early aggressive management. So they weren't listening for breath sounds when they were bagging. If the patient was coding and had trauma, they opened the chest and they got a bunch of people back with some good outcomes. So obviously that all the single system stuff, this is a pretty high-end system in Texas. There's a lot of QA challenges in training folks to do this, but it's possible and we should keep it in mind. So again, finger thoracostomy, it's basically putting in the chest tube without putting in the chest tube. Everything else is the same. Landmarks, preparation, dissection with a Kelly, stick your finger in, clear the pleura, and then you kind of almost burp their lung with your finger to get as much air out as possible or blood out as you're doing it. This is their improvised tube thoracostomy, which they actually used a bougie as an introducer. So use what you had. So they made the hole, they thread a bougie into it, and then they put as large an endotracheal tube as they can over that, and then rig it up to suction. And it works pretty well. And then we can skip this because I think I'm out of time, but in the air medical environment, where you have patients who develop pneumothorax from ventilation, they also had good survival. A 27% survival rate in this particular retrospective review. So there's a space for doing this skill in the pre-hospital environment. Needle thoracostomy is important. Know that you're going in the right spot. So go big if you're going anterior, or if you've got the 5 centimeter needle, go lateral. We'll skip the kid stuff. I cut that out for time. Secure it so it doesn't kink. Don't be afraid to repeat if that's all you have. And then field thoracostomy, finger thoracostomy techniques are an expanding EMS intervention that you're probably going to see more of. probably in the Rhode Island setting, it's going to be agency by agency as a special project kind of closely monitored thing. But there's enough evidence right now that I think we should at least have a conversation at the state level about training a cadre of paramedics to perform this. Any questions? I know I went through that quick.